Well, good morning, everyone. It's my great pleasure on behalf of the department's DEI committee to introduce to you our first Grand Round speaker in what will be a series of Grand Rounds on topics related to diversity, equity, and inclusion. So our speakers today, and we have two of them, are Dr. Andrea Deyrup, who is a professor in the Department of Pathology at Duke University, where she is the director of undergraduate medical education and also the first-year pathology course director. She's a graduate of Princeton University and received her MD, PhD degrees from the University of Chicago, where she also did her pathology residency training. And that was followed by a fellowship in soft tissue pathology with my friend Sharon Weiss at Emory University. She's one of the co-editors of the newest Robbins and Catran textbooks, Essential Pathology, and she's actively committed to anti-racism efforts and to improving discussions about health disparities in medical education. Our second speaker is Dr. Joseph Graves, Jr. He is the professor of biological sciences at the North Carolina Agricultural and Technical State University in Greensboro, which is the largest of the historically Black colleges and universities in the US, and a land-grant institution like the University of Minnesota. His research is in evolutionary genomics of adaptation, specifically antimicrobial resistance of bacteria to nanoparticles. Dr. Graves is a graduate of Oberlin College, and he received his PhD in environmental, evolutionary, and systematic biology from Wayne State University. He has authored multiple books on the biology of race, including The Emperor's New Clothes, Biological Theories of Race at the Millennium, The Race Myth, Why We Pretend Race Exists in America, and Race and Racism, Answers to Frequently Asked Questions, which he wrote with Alan Goodman. So we are so grateful to both Dr. Deyrup and Dr. Graves for being with us this morning. I've seen an early vision of their presentation, and it's spectacular. So thank you both, and we enjoy having you here at the University of Minnesota.
All right, well, thank you very much, Dr. Powell. We are also absolutely delighted to be here. Let me share, move this over here, close that. Excellent. So all of the fabulous icons at the top belong to Dr. Graves, who is a very powerful and potent speaker and researcher. So I'd like to begin with a disclosure. I am, as was mentioned, a co-editor author of two of the Robbins pathology textbooks, Robbins Essential Pathology and the upcoming 11th edition of Robbins and Kumar Basic Pathology. And Dr. Graves, I'm delighted to say, is a paid consultant for this 11th edition as well. What we'll be talking about in this presentation will be the 10th edition of Robbins Basic Pathology, which was still heavily invested in race-based medicine. So our objectives will be to discuss the impact of systemic racism in medical school curricula, to compare and contrast biological and socially defined race, to evaluate disparities in the pathophysiology of disease, and to describe an approach to addressing health disparities in medical education. So how does race show up in the curriculum? I'm a pathologist. Robbins Pathology is my textbook. So in order to get an idea for this, what I did was to take Robbins Basic Pathology and look in the e-text using a variety of terms such as Asian, Caucasian, African, African-American, Hispanic. And looking at this, I found more than 45 diseases for which some sort of disparity was mentioned, either in prognosis or incidence prevalence based on socially defined race. So let's take a look at how these disparities are actually stated in the text. So here we have some quotes from the 10th edition. 4% of African Americans with transthyretin mutation risking cardiac amyloidosis, carrier frequency of cystic fibrosis in Caucasians, cholesterol gallstones in Native Americans, and factor V Leiden in whites. So let's first just set aside the inappropriate and outdated terminology, because that's easy enough to fix, right? You can do that with find and replace on Word. let's look at the actual intention and meaning of these sentences. So when these statements were written, they were written with the best of intentions. It was believed that these epidemiologic data would help future physicians to develop an appropriate and broad differential diagnosis, to order the broad range of laboratory tests to address that potential diagnosis, and then to design the appropriate treatment for those patients. So the belief was that these epidemiologic data were helpful. But it's not enough to simply say, well, we had good intentions. We have to ask, is there any way that we're causing harm? So are we causing harm? And I believe that we are. And there are three realms that we'll explore. One, beginning with what I call buzzword bingo. So what I mean here is that we take very motivated, very bright medical students who are extraordinarily good at multiple choice questions, and we teach them simple word associations: white, cystic fibrosis; black, sickle cell. And then we reinforce this through our exams, our quizzes, through clinical vignettes and cases, even the national boards. So we are reinforcing these buzzwords. So let's look, for example, at a website from 2015 looking at race and the board. So this is a sardonic, ironic recommendation from a resident about rules for step one for medical students. And I think as we read this, we feel a certain amount of horror, but also recognition for all of us who are attendings, residents and fellows. We learned these very associations when we were in medical school, and we also knew that they were important for our step exams. Let's look at a more recent publication here. This is from 2017, done by the excellent researcher Deborah, who also wrote a very important book on pulmonary function tests called Breathing Race into the Machine, which I highly recommend. In this particular paper, she and her colleague looked at UWorld, which is a test prep resource used by, I would say, every single medical student who is preparing to take step one. She and her colleague looked at the entire database of questions, and they looked to see which races were mentioned, and they took a count to see whether the race or ethnicity was simply descriptive, like it's a white person who has a cold, or a Hispanic individual who's in a motor vehicle accident, or whether it was central, that knowing that person's race or ethnicity was key to getting the correct answer, either because it told you about a disease propensity or risk or appropriate treatment. And what they found here is you can see that white/Caucasian showed up in about, let's see, it actually showed up in 86%, it showed up in actually the vast majority of the cases, it was white. And this is despite the fact that white, so it was 86%, sorry, my apologies here. In 86% of the vignettes, the person was described as being white or Caucasian. However, whites and Caucasians only make up about 62% of what we see in America. Now, most of the time, if that individual in the vignette was white or Caucasian, it was descriptive. It didn't matter that that person was white or Caucasian. About 7% of the time it did, and this was most likely going to be something like cystic fibrosis. However, if a Native American is showing up in your vignette, it is because that person is Native American. It's not because they were in a motorcycle accident or they brushed up against poison ivy. It's because they have severe combined immunodeficiency, gallstones, or diabetes. So, are we causing harm through buzzword bingo? You may say that this is, simply the preclinical years. And surely, our medical students, as they go on the wards and they become residents and young attendings, they'll learn the full spectrum of health and disease, and they will shed this misinformation. And I would counter that simply by saying, there are things I learned 20 plus years ago at the University of Chicago that I did not learn were wrong until I began really looking at race in medicine. So then the next question I think we have to ask is there a way we're causing patient harm? And again, I say, yes, I think we could be. So say a young Navajo woman presents to an acute care clinic, she has right upper quadrant pain, and the physician thinks, oh, Native American, must be gallstones, and completely overlooks acute appendicitis or an ectopic pregnancy, either of which could kill the patient. Now you may think, well, this doesn't happen. We've got checks and balances. We have algorithms. Well, let me counter that with a published account here from the Misuse of Race in Medical Diagnosis, in which the author recounts a story of a childhood friend who wasn't diagnosed with cystic fibrosis until she was 8 years old. This was despite presenting multiple times with suspicious symptoms. And in fact, this child was only diagnosed by a clinician who could not see the color of her skin and looked at the chest radiograph and said, who's the kid with cystic fibrosis? There have been some other accounts recently in JAMA talking about how cystic fibrosis is not a white disease. And in that particular article, there was an African-American who wasn't diagnosed with cystic fibrosis until he was 54. So yes, I think that we can be causing patient harm. So finally, as long as we're looking at it, we have to take the big picture. Is there a way that we're causing harm to society? So are we, for example, lifting up one population and pushing down another, saying, bad genes, risky behavior, non-compliant? Is there a way that we are causing some sort of race-based hierarchy? So to make this easier for you to see, I will now redline for you all of the diseases in Robbins for which we say there's a worse prognosis or higher incidence in individuals of African descent. And for comparison, we can see for European descent. So I think we can say that there is this drumming narrative of the diseased African. And I'm going to turn this over now to Dr. Graves to talk about exactly what is race.
Thank you, Dr. Deyrup. Race is the elephant in the living room of American society. But exactly what do we mean when we use that term? In modern biology, races are defined by two criteria. The first being the amount of genetic variation within and between groups in a species. And the second, whether any group within a species can be considered a phylogenetically unique lineage. Now, it's long been known that in anatomically modern humans, that there's more variability within the so-called races than between them. Now, we do have geographically based genetic and physical differences, but any two individuals drawn at random from any two places on the planet share 99.9% of their DNA. Next. Now, this is enough to demonstrate that biological race does not exist in our species. However, we do have socially constructed or socially defined race, which arbitrarily utilizes aspects of morphology, geography, culture, language, religion, or any other thing that you can throw into the mix in the service of social dominance hierarchy. And that is why my book with Alan Goodman is entitled Racism, Not Race. And we make the point in the introduction that it was racism that created our socially defined races, not the underlying biological variation within our species. Now, this recognition is beginning to gain some traction in modern biomedical research and clinical practice. For example, Merrill's Introduction to Epidemiology in the 7th edition states, race is a socially constructed variable based on the idea that some human populations are distinct from others according to external physical characteristics or places of origin. Next, please. However, racial or ethnic variations in health-related states or events are explained primarily by exposure or vulnerability to behavioral, psychosocial, material, or environmental risk factors and resources. So please note here that Merrill does not say that these variations in health-related states are the result of genomic differences between supposed biological races. Next. Now, this is even further indicated when we look at, the confusion that exists within things like the US Census. Now, it's important to recognize that the census actually tells you that these categories are neither scientific or anthropological, but they are still being used. So, for example, white, a person having origins in any of the original peoples of Europe, the Middle East, or North Africa. But then the question becomes, how much of that ancestry makes you white, Black or African American, a person having origins of any of the Black racial groups of Africa. And again, we can ask the same question, how much? And it is really important to recognize that Africa contains more genetic variability than all of the rest of the world combined. American Indian or Alaska Native, person having origins in any of the original peoples of North and South America, including Central America, but who maintains tribal affiliation or community attachment. And this is equally problematic because an American Indian who no longer maintains tribal affiliation no longer classifies in that group. Or what do you do with people like the Black Seminoles who fought slavery and escaped to Florida and became members of the Seminole Nation, but they have African origin? Asian, person having origins in any of the original peoples of the Far East, Southeast Asia, or the Indian subcontinent. And that in and of itself illustrates how completely useless this designation is when you consider you're talking about people from Cambodia, China, India, Japan, Korea, and on and on and on. Finally, Native Hawaiian or other Pacific Islander, person having origins in any of the original peoples of Hawaii, Guam, Samoa, or Pacific Islands.
All right, thank you, Dr. Graves, for talking us through some of the thoughts around race. So let's look at race in the context of disease. So for those of you who are physicians, even students, you will, of course, recognize that in this map, we're looking at genetically based resistance to malaria. These are the hemoglobinopathies. And as you'll recall from your studies, the hemoglobinopathies are based on evolutionary pressure that selects for these hemoglobinopathies because it offers some protection against malaria. So as we look at this map, we can see broad swaths of thalassemia. We have some hemoglobin S and hemoglobin C. And there are a couple of things I want to point out to this, about this to begin with. So oftentimes we'll refer to thalassemia as being, associated with Asian heritage. And yes, in fact, according to the gigantic definition of Asian in the US Census, yes, it does affect some Asians. But there are a lot of Asians, in fact, most Asians, because here we have China, as well as Japan, and other areas here of Asia, where there absolutely is no thalassemia. And then when we think of sickle cell disease, right? So we always talk about this in the United States as the African American disease, right? Well, we can see that there are large areas of Africa that do have sickle cell. It's also present in Southern Europe, as well as the Middle East and areas of India. And there's been some recognition that we are underdiagnosing sickle cell disease in Indian Americans because it's not being thought of, because sickle cell is the African American disease. But let's think about what this map is showing us. What it's telling us is that your propensity for this disease, your risk, is not based on geopolitical borders like the border of your country or even your continent. What it really is based on in this particular instance is, were there mosquitoes that carried malaria? So if we look here in Africa, I think it is made most abundantly clear here, we have this area where there are no hemoglobinopathies, none. Why is this? Sahara Desert. Sahara Desert, no mosquitoes, no malaria, no selection pressure. Okay, so this is, I think, a big picture that helps show why even looking at geographical ancestry can be challenging. So let's cone down here on Africa, because as I mentioned, we do have a focus in our country on sickle cell disease as being associated with African Americans. And you can see here we do have in Central Africa, there's a significant amount of hemoglobin S, and then hemoglobin C is primarily here in Western Africa. And if we are to compare this with a map showing the origins of enslaved peoples earlier in the history of our country, you can see why we have hemoglobin C and hemoglobin S in this country, all right? And this is confirmed here by just one single study at Howard University, part of their sickle cell screening clinic, where you can see that while the majority of individuals have a wild type hemoglobin A, we have a significant amount of sickle cell hemoglobin S, as well as hemoglobin C. So you may be putting the story together and thinking, okay, I can't think continent of origin or country of origin, but if I start thinking about evolutionary pressure, but you can't just look at somebody's skin and think that tells you something about where they're from and what their genetic ancestry is. Because here we can see from this article here, you have to keep in mind that a rising share of the U.S. Black population is foreign-born. So they are not the they are not the descendants of individuals from chattel slavery. And then we have to also consider the fact of population admixture. So the mean amount of European ancestry is about 16% for those African Americans who are descended from enslaved persons. And so this is adding additional genetic material into the mix. And population admixture is so important that Dr. Graves is going to go into a deeper dive.
And thank you, Andrea. So when we look at the percentage of European ancestry in persons socially defined as African American, it differs dramatically depending upon the portion of the country. So while the mean may be around 16%, different states, for example, in West Virginia, it's northward of 30%. And the same is true of Washington State. Next slide. Now, when we consider people defined as Latino, which is an ethnic group, their percentages of European ancestry vary dramatically from 65 to 85%. But it's a triad mixture, which includes African and Amerindian ancestry. Next slide. So when we look in the Caribbean, for example, on the island of Puerto Rico, the average European ancestry is about 72%, with 16% Amerindian ancestry and 12% African ancestry. And there are more Puerto Ricans in the continental United States than there are on the island of Puerto Rico. But when we compare those individuals to people from Mexico, Mexican Americans are on average about 51% Amerindian in ancestry, 46% European, but only 3% African. And then when we look at some of the some of the South American nations like Colombia, they have a admixture portfolio that looks something like in between Puerto Rico and Mexico. And then if we look at Peruvians, they are 80% Amerindian by ancestry and 18% European, with a very small percentage of African ancestry. But even within the nation of Colombia, you can have dramatic differences in different parts of the country. Next slide. So for example, in the city of Medellin, you see, the triad mixture looking very much like the national average. But in the neighboring state of Choco, which was a center of plantation agriculture and had large number of enslaved Africans, their triad mixture looks very much like African Americans, although it has a much higher percentage of Native American ancestry included.
Excellent. Well, thank you, Dr. Graves. Now, I want you just to think about this. So both people from Medellin and Choco would be considered Hispanic. So let's just take a look at this. There's a lot in the slide. I'm not going to go deeply into it, but I just wanted to highlight something for you. So this comes from a paper looking at melanoma subtypes by socially defined race. And this is using the SEER data. And I mention this because SEER data are used a lot, and it's important to recognize the limitations. So we all know, right, as physicians, that your tendency for melanoma is going to be based on the amount of pigmentation in your skin, right? We know this. So melanin is protective. We teach this to our medical students, and there is this belief that melanoma is incredibly uncommon in patients of African descent. But if we look here, and this is based, I just want to make the point here that we have it here based on non-Hispanic white in blue, Black is in orange, Asian Pacific Islander in gray, and then Hispanic white here. So Hispanic white, right? So we often will talk socially about Black and brown peoples and are including Hispanics in that. But when we're talking about SEER data, because of political ways of looking at people, they are considered white. And so there's definitely a disconnect. And part of the issue that I'm pointing out here is that we know that superficial spreading melanoma is something we tell all of our medical students to look for in your blonde and red-haired patients, but we're missing it in our African American patients, right? So they are presenting now at a later stage, right? So these labels that we're using have a tremendous impact on patients. Now, going back to what Dr. Graves has been discussing, I think it's quite clear that race is not a biologically useful construct. So why then are there racial disparities in health and disease? So there are some genetic bases for these disparities, and I would refer to these as intrinsic causes of disparities. So this could be like a founder effect or a population bottleneck. So this could be a severe combined immunodeficiency in the Navajo, perhaps Tay-Sachs in the Ashkenazi Jewish population. Both of these groups were decimated in the Holocaust and in the American genocide of the Native Americans. But what we're looking at here are not races, they are specific populations. Now, another cause of allele differences, allele frequency differences, would be endogamy. So this is marriage between, or more specifically, breeding within a particular group. And this can be due to religion or caste or geography. But once more, it is not a race, it is a population. And finally, we have selective advantage, such as sickle cell or the hemoglobinopathies, and which we talked about earlier, and that's related to geography. Again, not races. But while we spend a lot of time focusing on allele frequencies and doing genome-wide association screening, the primary mover and shaker of disparities, health disparities, particularly in this country, are the extrinsic causes. So poverty, stress, access to care, living conditions, food access, neighborhood. Many of these are related, and all of these, I would say, are shadowed by individual, institutional, and systemic racism. Now, these last three terms are coming into use more and more often in the popular press, even in some scientific articles. Let's take a moment to be on the same page. This comes from the website dismantlingracism.org, which I highly recommend, and talks about the three types of racism. So personal racism is what I thought most racism was. I live in North Carolina. I envisioned racists as being men in white robes burning crosses. And I think as a country, we have come to recognize that far more pernicious and ubiquitous are institutional and systemic racism. So institutional racism would be considered the policies and practices of institutions like universities or hospitals that include and serve and financially resource white people. And a medical example of this would be that when the first phenylketonuria screening testing was begun, it was done in that first clinic only in white children because of the belief that only white children got PKU, which we know is not true. Cultural or systemic racism are beliefs, values, and norms that, again, uplift and validate and protect white populations at the expense of people in communities of color. So some examples of this would be our society doesn't believe in universal health care. And you know that this has a tremendous impact on health disparities. Also, our government practiced redlining, which made it more challenging for African Americans to get mortgages and own homes, creating generational poverty, which, as we know, is associated with health disparities. So let's take a look at these in the context, these extrinsic factors in the context of disease. So here's a quote from UpToDate based on the two papers cited below. As you know, when it comes time for a hysterectomy, there are two categories, large categories to look at. One is an open hysterectomy in which there's a fairly sizable abdominal incision, which the healing from that has a significant amount of morbidity, takes a long time to heal. You can't lift heavy objects. And then there are minimally invasive hysterectomies. So it could be a laparoscopic hysterectomy or a vaginal hysterectomy. And what these studies showed is that women who were eligible, so they had a uterine size that was compatible with either approach, if they were Black, Hispanic, or publicly insured, they were much less likely to receive that minimally invasive technique compared to white women. And I would say that the factors involved in this would be systemic racism based on the criterion of public insurance, institutional racism because the hospitals that serve these populations had fewer surgeons that could perform minimally invasive techniques, and then poverty, education, access to care, health insurance. And then if we look at this statement from the 10th edition of Robbins' Basic Pathology, looking at high blood pressure and the increased impact on African Americans, I would say that all of these are a factor. There is no slavery gene, despite what people say in the popular press. All of these factors are contributing to hypertension. So one of the things that I've done for my students, and I'm welcome to share this, I'm happy to share this with Dr. Powell, is once I came up with this list of diseases, you can't just ignore it at this point, you have to do something with it. So I did a deep dive into the literature, generating a paper that's about 70 pages long with references and figures. And I've been sharing this with my medical students, and I've been making videos based on this. And I'll give you the link to my website and my race and medicine videos. But just to give you an idea of what we're doing, and part of this work is so that we can change it in the upcoming edition of Robbins, right? So we need to look at the data so that we can address how we move forward. So one thing that people could say is, well, race is problematic. Let's just remove all mentions of race from all textbooks. And while I think the science will support that for the vast majority of cases, I think the pushback from systemic racism will overwhelm it. And so in order to move forward, what we have done is to do the dive into the science. So let me show you what one of those deep dives looks like. Let's do cardiac amyloidosis. So this is the sentence in Robbins. I referred to it earlier: transthyretin mutation, increased risk of cardiac amyloidosis. As you may recall, transthyretin transports thyroxine and retinol in the blood and CSF. And while secreted as a tetramer, it can dissociate into monomers, which can misfold and aggregate into amyloid fibrils that can be deposited in the heart, nerves, and other tissues. Now, in 1989, a pro-amyloidogenic mutation was identified in a 68-year-old African-American man. And since that time, we have found that about 3 to 4% of African Americans have this allele, compared to about 0.4% of European Americans. It's an autosomal dominant, variably penetrant mutation, and tends to affect men over 60, which is important because it can mimic hypertensive cardiomyopathy, which is also prevalent in that population. Individuals with this diagnosis tend to die 2 to 6 years after being diagnosed. Now, based on this allele frequency, it was thought that there might be some sort of founder effect. And we're quite fortunate that the research was actually done. And you can see here the distribution of this particular allele in Africa, with a concentration in Western Africa and then across Central Africa as well. And if we compare this again to the origin of enslaved peoples from our history, you can see why we do have an increased percentage or increased prevalence of this allele in this population in our country. Now, if this were all we had, we'd have an interesting story, but not much to do about it. But it turns out there's actually a medication that can be used to treat this. It prevents dissociation of the tetramer. So it does not cure the disease, it does not roll it back, but it slows progression. Now, one problem is this medication costs about $225,000 a year. Now, part of the reason for that is it's considered an orphan drug, and there aren't people who are advocating. There aren't lobbyists for this population. I think, again, due to systemic racism. Who is it who gets this disease? African Americans. Who is lobbying on their behalf? So there's a lot that we can do with this. This brings us back to our original question: is race in medicine data or distraction? And I hope at this point in the talk, you've all said, oh, you can't, race is not useful. So is a focus on disparities in medicine data or distraction? And I would say, yes. It can be data if we take information, for example, looking at severe combined immunodeficiency in the Navajo and develop a newborn screening program so those patients can get the stem cell transplants they need. It's data if we are recognizing that an African American who's a man and is in his 60s, and it looks like he has hypertensive cardiomyopathy, but gosh, he doesn't have hypertension. Wait, let's look into this further and see if there's a way we can treat him. It's a distraction if we do what we've been doing for generations and saying white equals cystic fibrosis, black equals sickle cell disease. So what do we do as educators, as physicians, to make disparities and our focus on that data and not distraction? So first, we have to be inclusive. And I'm going to talk about each of these points. We have to have thoughtful, mindful analysis of the material driven by data, and we have to provide context. So what does inclusivity look like? This is what it looks like to me, beginning with Dr. Kenyon Rayleigh on the far right, and then, of course, Dr. Graves here. But as these two individuals have been incredibly important to me in my journey, but we can't just say, I've got my two African-American, colleagues and I know what's going on. You have to continuously expand. And so my team has grown the more anti-racism work I've done. And I will tell you that I have been more and more challenged by the people I brought onto my team. So as you're building your team, it may be good, just from a point of view, to start off slowly and gently, and to keep in mind you have to do your own work. You don't just stroll up to someone and say, hey, I'm ready to be an anti-racist, tell me what to do. It's so critical for those of us who want to be allies, co-conspirators, that we do our work, that we come here ready to work, not just, hey, coach, what is this brown pointy thing with laces on it? We need to come out on the field ready to play. And we need to include the medical students and the residents, right? So they are younger. They're in a time when they are questioning. Many of us are working so hard on just, moving the meat, passing the glass. We're not thinking about these, but our younger physicians in training are thinking about this. And this is challenging for us often as professors to reach out, to show that humility and vulnerability, because we're professors, we profess. There's a medical hierarchy, and I've clawed my way to where I am, and I want respect. But we have to be vulnerable. We have to be transparent. We have to reach out, because this is how we learn. So this is what I did for the 11th edition of Robbins, as I reached out and I said, hey, students, if you see anything in the book that you don't like, I put up a Google Doc. It's completely anonymous. Let me know. Duke students don't like to be anonymous, so they basically filled my inbox with issues, and we are addressing them in Robbins. We also need to be very mindful of inclusive images. So at Duke, since 2016, under the influence of Dr. Rayleigh, I removed all mentions of race and ethnicity from my clinical vignettes in my questions and the cases that we use for teaching. But as you can see, we still have clinical images, and I thought I was doing pretty well because they were roughly divided. We had a fair, of 100 cases, maybe 50 of them showed, patients of European descent, and 30 were patients of African descent, and we had some Hispanic. We had it all in there, nice mix. But what I've recognized is that that's not enough. We can't just say, and here is the canonical basal cell carcinoma on this person of European descent. We now include on our website, here's an alternate image of a basal cell carcinoma in an individual with a darker skin tone. Why is this important? Well, I think for many of us looking at that, our first thought is, oh my gosh, that could be a melanoma. Look, it's got, asymmetry and border and color and all of this. And if we don't teach our students this, then they're going to miss some things and then overdiagnose others. So you have to be inclusive with your images. And we are doing this in Robbins. We are bringing inclusive images, and not just the images, but the text. How many times have you read psoriasis is characterized by salmon pink plaques? Well, they're salmon pink if you have lightly pigmented skin, but they're not if you have darker skin, in which they often appear hyperpigmented. So we have to look everywhere for this. It's very sneaky how systemic racism has infiltrated everything in medicine. So this is what I task all of you with, right? Question everything. Dr. Powell and I were talking earlier about a video that I did specifically on this quote. I'll give you a link to that. So this is the quote that's in the 10th edition of Robbins. I emailed the author of that chapter and I said, most respectfully, I would recommend that we remove this particular phrase. And I was told, well, this is what it says in Up to Date. Now, because the disparities document that I'd written, not only had I read Up to Date, which is always a good place to start, but I had read reference 5. In fact, I've read every reference on keloids. And found this statement in that, in addition to the 5 to 16%, my eye was caught by this statistic that the risk of developing keloids is about 15 times higher in dark skin compared with whites. Now, this is a large number. 15 times is pretty significant from a statistical point of view, but it also caught my eye because I'd seen it in 4 other papers. Now, it looks like the primary source for that, or the incident paper, as you will, was Brissett, because this was the earliest incidence of this quote I found. And this is what Brissett says. Right. In 2001, Brissett says, in review of 175 cases of keloids from various races, the authors found that keloids were 15 times more likely to occur in darker skinned individuals. Well, with the tenacity of a bulldog, I went after that paper from 1969, which was research that was done in Malaysia, hence the focus on Chinese, Indians, and Malays. And you can see that, first of all, the arrow is pointing in the wrong direction, because what the authors actually found was that the relatively fair-skinned Chinese were slightly more prone than the dark-skinned Indians and Malays. Now, I did the math myself. It's about 2 to 3-fold increase. So we don't have the numbers wrong. So we have the arrow in the wrong direction, and we have the fold increase wrong. So I presented all of this to the author for Robbins' Basic Path. And this is what we ended up with. Keloid formation seems to be an individual predisposition, which it is. But this brings us to, we always have to look at the next order, the systems of this, right? So why are we even making this association in the first place? How does this matter, right? So if an individual is going to develop keloids, I don't need to look at the color of that person's skin. I can look at that person's actual skin. So as an adult, most of us have had some sort of trauma, previous surgery or a scrape or a piercing or multiple piercings. And if I'm going to develop a keloid, you can look at my skin and you can see, oh, yes, I see you had an ear piercing, you have a keloid, right? Now, we do know, for example, with children, that they may not have had as much trauma as the rest of us have accumulated, and you may not be able to just look at their skin. But we can also know that we should do a family history, a close family history. So you ask, do your brothers and sisters have keloids? How about your cousins, your aunts, your uncles, your parents, your grandparents? And we can use that approach not just for something such as keloids, but for all diseases, because this will tell you more about that person's geographic ancestry and genetic background than anything related to socially defined race, as I hope we've demonstrated in this talk. Furthermore, it's going to encapsulate things that are part of culture. So is this a group that has a particular folk medicine they use, or a diet, something that they eat that's unusual, a tea they drink, right? By asking which diseases are in your immediate family, you will tease these out. So as I mentioned, I did about a 20-minute video on this. Please take a look at it. You can screenshot, or you can just go to pathologycentral.org, which is a website in which I have a bunch of race and medicine videos. So how did this help? Well, that particular video, I sent it to the authors of UpToDate, and I said, here are the data. I really believe you need to remove socially defined race from as a risk factor for keloids. So you can see here the 5 to 16%. And then what it looks like now is they have removed it. So science has in fact prevailed in this instance, but it's everywhere. It is the Hydra. You have to keep looking and knocking it down. So finally, as far as advice to how we can do this appropriately, we have to use the right terminology and we have to provide context. So this is a sentence from the 10th edition of Robbins' Basic Path, looking at factor V Leiden in whites. Now, in the future edition, the one we're working on, we're not using colors because I think if you use whites, you got to use brown, blacks, yellows, and reds, and nobody wants to do that. Now, in this particular instance, we know that this is a mutation. This is genetic. So we want to emphasize ancestry. So here we're going to say that it's in 2 to 15% of individuals of European ancestry, but we don't want this be code word for white. Right? We don't want this to be, hey, medical students, when Deyrup says European ancestry, she means white. We need to give them a further nudge and say it can be present to varying degrees in other American groups, largely due to population admixture. This is particularly relevant for factor V Leiden because, as you know, heterozygotes can be prothrombotic as well, right? So we need to be sure that people are not checking off some little box and moving on. This is a list of my references. And we'll take questions. I'd like to give you some ways to get in touch with us. So you can email me or Dr. Graves. We are both on Twitter. This is my website. I put content up on a weekly basis. For those of you in pathology who are interested in diversity, and even those of you who are not, who are you want to share this with your student interest group, Diversify in Path is a podcast that has a rich spectrum of individuals in pathology from different backgrounds and offers a lot of insightful material. I was interviewed on that. You can find that here. And then I'm finishing up here with an image from a brilliant cardiology fellow at the University of Chicago named Dr. Obobi. And I think this really encapsulates this. Go ahead and take a screenshot and keep this in mind, right? That this is what our students are experiencing, and this is the impact of systemic racism. So you can follow her on Twitter as well, or check out her website for her insightful and incisive comments. And with that, we will take any questions.
Excuse me. Hi, my name is Dr. Vanessa Dayton, and oh my goodness, many years I've been one of the faculty in a class that used to be required at the University of Minnesota Medical School. Now it's an elective for junior and seniors, or third and fourth year medical students. It's ordering and interpreting laboratory tests. And because I have read some of the things that you and Dr. Graves have done in the last 2 years, I'm sorry, I have to step back. For many years now, it's an expectation of the course that we teach from actual patient cases. So every year, while I'm being consulted on different things, if I find an automated complete blood count, and I'm asked to look at a blood smear, and I put all the information together, and it's like, oh, okay, this is a great case to teach the medical students about iron deficiency or B12 deficiency, or that those cases of sickling diseases like SC disease that may present in the first year of life, or you may present with your first chest crisis when you're 71 years old and no one would have thought of it, okay? I have, in the last few years, put out a disclaimer at the beginning of each lecture, where every single lecture I give has cases, is case-based. I say that I no longer include ethnicity in the brief patient histories, but that students should always be aware that ethnicity may be a clue to what's going on. And then I work from there. Is that appropriate or inappropriate? How do medical educators who do these case-based lectures treat this as sensitively as possible, but get it in the students' heads that they always have to be thinking of rank ordering their differential diagnosis? Okay, thank you.
Joe, I'll let you address the science, and then I'll address my particular way of teaching at Duke.
Yeah, thank you, Andrea. So thank you, Dr. Dayton, for your inspired work, first off. One of the things that I always point out to people is you have to be really careful about what terms you're using. So if you use the term ethnicity, and it's commonly used incorrectly across the board, not just in medicine, ethnicity is defined as people who share a common language or religion or national origin. And so that doesn't really tell you about, geographically based biological variation. So they're not the same thing at all. And you're absolutely correct. When we look at the variability of, allele frequencies within, populations that are socially defined as race, I put in the chat, for example, that our colleague, Dr. Charmaine Royal, works upon, the question of the variable penetrance of sickle cell disease. And folks are misled to think that, if you get the sickle cell allele, that you're going to necessarily display sickle cell disease. And that's just not true. So how and when it happens depends upon a lot of factors. And also, of course, as Dr. Deyrup pointed out earlier in the presentation, that the sickle cell allele is in variable frequencies across endemic malaria zones. And for example, Greeks have a higher frequency of sickle cell anemia than African Americans do. So, you're doing the right thing. And, we have been working very hard. And one of the analogies that I'm going to disagree with is the notion of the Hydra. Because if you remember, the Jason and the Argonauts, as long as Jason was cutting off heads, the Hydra kept growing new heads. He couldn't defeat the Hydra until he pierced its heart and killed the beast.
No, fire.
Yeah.
Fire. You need
Oh,
fire.
the fire?
Yeah. If you sear off the heads, it was Hercules, I believe.
Well, yeah, we watch different movies. But at the end of the day, the point is you have to kill the beast. Cutting off heads isn't going to do it.
Okay, so well, we'll continue to have. I don't actually watch movies with hydras. I recall that from Latin in 7th grade, so I may be wrong on that. But to talk to your point, so yes, the actual point of the question has to do with medical economics, right? So there's rank ordering your diagnosis, rank ordering your tests, right? So if an African-American kid comes in with pneumonia and then comes back, a year later or 6 months later with pneumonia, your first time when you first see that kid's not be, oh, this is undiagnosed cystic fibrosis, right? Unless you're a medical student and you hear hoof beats and you think zebra, right? And so I think there are two things that are important to think about. Firstly, as Dr. Graves says, it's critical to define your terms and to be very clear that what we're talking about, there are some allele frequency differences that we're thinking about, right? And so you have to look at, is that the context you're looking at? Does it have to do with the allele frequency? Are we talking about something genetic like cystic fibrosis? And I actually have a video on cystic fibrosis because the newborn screening is heavily weighted towards European alleles. So it's less likely to pick up cystic fibrosis in an individual of, Asian, African, Hispanic descent, et cetera. Although actually Hispanics have a significant European component. So are we talking about something which is genetic? Are we talking about something which is a socially defined, it's due to systemic racism? Now, what my thinking is, and let's just look at the cystic fibrosis example, is that we don't want to, because of limited resources, we don't want to say every kid, African-American kid who comes in with a cough, we're going to go ahead and do another cystic fibrosis test on. So maybe you don't catch them the first time, but maybe the second time. So I think the lesson can be, you can be aware of genetic risks in certain populations which are not associated with socially defined race. So once more, it's populations, not race. You can be aware of that. But if you get a result that does not correlate with your thinking, instead of writing that off or thinking, well, it can't be cystic fibrosis because he's Black, think, could this be? And we're actually working on something. You guys will be the first to hear it. I suppose we're supposed to publish it first or whatever, but I don't really personally care about that. Something we're introducing next Thursday in Duke in the pathology course is, everyone's familiar with the mnemonic Vindicate, right? So it's for differential diagnosis, so vascular infection, neoplasia, drugs, et cetera. We're adding a D to the end, so it's vindicated, which I think is actually somewhat appropriate. And that D stands for diverse/disparate populations. And the idea is, as pathologists, as you all know, and I'm sorry, I'm digressing terribly. Well, I'll finish my answer, but I think this is important. When I make a diagnosis and think, I do soft tissue, and in soft tissue, benign things look malignant, malignant things look benign. If I say this is benign, I stop and I think, okay, what malignant thing could it be that I'm not thinking of? And if I say, oh, this is clearly malignant, I stop and I say, okay, what benign thing could this be that I'm not thinking of? So what we're suggesting to our students, because the textbook currently is still race-based, because race-based medicine is part of the bones and the scaffolding and the meat and the fat of current medical practice, that we get to the end, right? We get to our E, endocrine, emotions, and we add a D, and we think, am I missing something because I'm thinking of a certain population? If I were to open this up and think, what if this person were a different socially defined race? Am I making an assumption about socially defined race? How about disparities? Is this person coming from a background with a higher exposure to toxins or particulate matter? And in that way, what we're asking people to do, what I'm asking our students to do, is to put people into context. right? And that, I think, is part of the answer to your question. So we're not going to say, well, we have an African-American woman who's just come in, she's 30 weeks pregnant, and she's a high risk of this because she's African-American. If that African-American is Michelle Obama, right, that's different from saying a different African-American. You have to look at it in the entire context of the social and political before you can make that. And I think to emphasize that, race and ethnicity are not a simple checkbox. They come with so much information and data. And just one last point, because I know that Dr. Graves is going to leap in here because of something I've said, which was probably not incredibly clear. But all the research that's being done where they say, we looked at, this particular variable, and even when we account for race, even when we account for social determinants of health, we looked at socioeconomic status, we looked at education level, we looked at, proximity to Superfund sites. When we looked at all these cultural determinants of health, race still had an impact. And what my argument is, and what I think was shown in that last cartoon I showed, is that we're not looking at all the social determinants of health. We don't know them all. There are things we don't know because race, socially defined race, has such a huge impact on health disparities. Dr. Graves?
No, I'm totally good with everything you said.
You're down with that? Okay.
Yeah, I'm totally good with that.
Then just quickly, should I replace the word ethnicity with disparities? I have removed from all brief clinical descriptions any disparities.
No. I mean, what I recommend you do, Dr.
Yes.
Dayton, and I'm not just doing this to try to sell books, but you should take a look at our book, Racism, Not Race, Answers to Frequently Asked Questions, because we have a chapter on this very question.
Perfect. Thank you.
What language do you use to effectively get across what you actually mean?
Thank you.
Amy Targer, do you have a question?
I do, yes. So first, a comment and a question. Thank you so much for talking about this topic. It's both personal for me, but also relevant to some things I'm doing in my career. I'm biracial, and my brother-in-law is African-American. And so your slides about the skin lesions really hit home because my sister has sent me pictures of lesions on my nephew's skin. And I've realized that I never learned what some of those things look, I always saw everything on Caucasian skin. So it's really brought that home. My question relates to research studies. So I'm involved in some research studies that have recruited different race groups. So there's one in particular that I'm thinking of that has a Caucasian group, African-American group, Chinese American. And this study was viewed as very, progressive because it was going out and recruiting people actively from different racial groups versus a lot of the studies that have focused predominantly on Caucasians. But then the consequence of that is that then the epidemiologists look at the data and then they create all of these race-based comparisons. So how would you suggest researchers proceed with these studies that have already recruited these race groups? It's very easy for them to analyze them by race group. I even just submitted a paper where they were mad that I didn't do more to draw out the race-based differences. And I was trying to tell them that this is not something we're supposed to be doing, but the reviewers weren't too keen on my comments. So I guess I'm wondering, what is your perspective on research studies and these types of comparisons?
Well, if you don't mind me going first on this, Andrea. So first off, people got to stop using the term race without qualification, because people always conflate biological and social definitions of race. So the folks that were being recruited in the studies you were describing belong to socially defined groups, not biological races. And as such, there are all sorts of ways you could analyze that data. And socially defined race, as I've always said, it's as real as a heart attack because it does kill people. My condition as an African American has shortened my life. I'm amazed that I'm still alive, to tell you the truth. It's a meaningful sociological variable. But if you're going after, genetic causes to disease phenotypes, then what you need to do is you need to sequence all of your participants And then you need to partition them by allele frequencies. And what you're going to find is that for most of these conditions, if you're using something like genome-wide association studies, you're going to find that all the groups you're describing overlap tremendously with regard to alleles that are associated with risk. And so that's the kind of analysis that needs to be done. We need to do more full analyses of whether people live by Superfund sites, what is their exercise level? What is their diet? What does their microbiome look like? The notion that you can just, sample people by socially defined race and learn something about disease causation is absolutely and thoroughly ludicrous. And by the way, no one in my field would do stuff like that. And since my field is the field that really defined all the methods that medicine is using, I don't know why, we're not consulted, because we invented this stuff. And we couldn't publish the kind of stuff that goes into medical journals as a phenotype genotype correlation. You couldn't do that in my field, but medical journals do it all the time.
Right. And I know this is very dispiriting because, first of all, not only is there so much literature looking at race, I mean, in the SEER database alone, right? Actually, I started trying to do a dive into how SEER assigns race, and it is hilarious, right? It's like there are all these different things that trump things. So, for example, Hawaiian trumps white, right? Whereas, Black will also trump white. And it also comes down to hypodescent, which is covered in Racism, Not Race, which I highly recommend. This is very dispiriting because so much of the literature is race-based. I think it's probably all garbage, personally.
Yeah.
I think that I think we could do, if according to what Dr. Graves just said, we could do it by astrological sign. Well, Pisces are much more, associated with this because race does not exist, right? And so, I have a Hispanic colleague who said, I've been asked to be on part of this big research project looking at brain tumor, frequency and outcomes. And they're going to be really good. They're going to do it, it's in Hispanics. And I said, oh, that's not going to work. And she said, but they're doing a really good job. They're doing like of Colombian origin. Well, think back to the slide we just showed you of Colombia, 60 miles apart, a city where there were no slaves and plantations where there were a lot. The genetic differences were huge, right? So race is only useful in medical articles, in medical research, as it relates to disparities based on systemic racism. So are people getting vaccinated? Do they get access to care? Gosh, African-American women have a lower incidence of breast cancer, but they have a higher mortality. Why is that? Does it have to do with the fact that they don't get they can't afford treatment? They don't have someone to take care of their kids. Basically, and this is very controversial, but I think that, if instead of focusing on these subtleties of allele frequencies, we were to take all that money and provide universal health care, we would do more for health disparities than anything that's going to come out as a publication in Science or Nature. So I know that's very inflammatory.
It's not inflammatory. I actually said that in the New England Journal of Medicine piece that I'm about to drop in the chat.
Yeah, so that's very helpful. I think one question I have, just to follow up really quick, I know we're over, but then are journal editors is anyone making an effort to reach out to journal editors, because they control the content? And I literally just got a review back, like I said, where it's on this multi-ethnic study, and they're upset that I didn't phrase it in terms of race, differences between the race groups, and put more emphasis on that. It was like talking. So
is anyone here a journal editor? I mean, this is why we're doing these.
I was going to say that I've actually been involved in doing that. So yeah. I was asked to consult with the editors of the MedRxiv and Nature and Science, and and they just dropped the ball. First that again, this was right after George Floyd was killed. And it's amazing, how consciousness just suddenly rose and people wanted to do the right things. But then as soon as the interest in Black lives died away, they dropped the ball. So the simple point is that the science behind what they're doing is completely and thoroughly bogus. This is why, again, we wrote Racism, Not Race. And people in the know. And what medicine needs to do is get into the 21st century with regard to human biological variation. And what galls me the most is if there was a new surgical technique that was invented that demonstrated clearly that it saved patients' lives, it gave you better clinical outcomes, everybody in the medical community across the country would be scrambling to get these new techniques into their curriculum and into their hospitals. But what we know this about human biological variation, that what people are doing now is completely wrong. But yet, because racism, and structural racism are such powerful determinants of what happens in American society, medical doctors who are primarily persons of European descent, African Americans are less than 3% of medical practitioners, because this doesn't really strike these communities in the way it strikes mine. Nobody's doing anything. So, schools like yours, you have an opportunity to make real substantial change. And I'm glad that you invited us to speak today, but the ball's really now in your court.
I want to thank both of you very much. And Dr. Graves, that last quote is exactly right. The ball is in our court. We need to educate ourselves better. I really appreciate your coming and kicking off what we hope will be a good series for our department, but we would like to invite you back again maybe next year to continue this conversation, because we could talk with you for hours on this. And I really think that if I take one thing away, it's that we should talk more to our colleagues in biology who actually did discover everything that we're using, but we haven't continued that dialogue, and it's important. So thank you both very much. We really appreciate this from our department.
If I may say one more thing about what it is you can do, right? So we gave this talk at Hopkins, and there was someone who was an editor-in-chief of microbiology textbook. She said, this is going to change how we address race. Each of you has the power to do this and do something. You're given a paper to review, and it talks about differences in race, right? You know that systemic racism is going to account for so many health disparities, and we can't calculate them all. Attack that. Go for it. Say to I do that in every paper master review. Oh, you mentioned race. Have you accounted for this? Why do you include race, right? The articles you write, the papers you choose, the research you go into. If you have friends who are on the American Board of Pathology, right? We gave this talk to Duke Pediatrics, and immediately I got emails saying, oh, we need to fix this. The American Board of Pediatrics also has issues. We've presented to the National Board of Medical Examiners looking at step 1 exams, right? We're trying to build a coalition to address this throughout medicine. So each of you, you're our army, right? You've heard this talk. If you are inspired by it, go for it. Work this.
Definitely should. Thank you.
Okay.
Thank you both
Thank you
very much.